What personality type are you? Do you know the different types of personality domains that define us inside and outside the operating room? Well, anesthesia can open you up like a book. In fact, this takes a couple of drops of anesthesia for our true personality traits to sometimes come up. I want you all to start listing the 5 behavioral traits, and I'm going to tell you how they reveal under anesthesia and the ways that sometimes patients themselves don't know that they have those traits. I'm going to give you a shout out as soon as I see one of those 5 come up. These are the 5 core behavioral traits. And if you don't know them, you can Google them and we'll go through one by one. I'm Dr. Anthony Comet, for those of you who don't know me, and we're going to go through the different behavioral traits and secret ways they come up. Darian, good to see you. Lava Demon. Myers-Briggs is kind of similar. You're right in terms of the core traits. Aggression is not one of them, though, Allie. Sorry, not one of them. And Steve, good to see you as well. Fear, anger, insecurity. These are not the core 5 traits, but they certainly come up in the traits. All right, I'm seeing clueless here, says Lynn. All right, number 1 is openness to experience. Openness to experience. This is the core domain that involves curiousness, eagerness to learn, being adventurous or creative. The opposite end of this spectrum is rigidity. So when we're when we're rigid and not able to take ourselves out of our familiarity zone or comfort zone. How does this come up in patients under anesthesia? Well, we have some patients that are so excited about anesthesia, believe it or not, maybe 1 in every 15 patients is so excited, they ask me to not give them midazolam or Versed. They want to have all their memories intact so that they remember every part of the anesthesia. So Lava Demon is saying ocean. That's correct. She got it. That's the acronym for these 5 domains that our personalities are based off. And it's those patients that have high openness. That's the O in ocean. They refuse the medication that nearly all other patients are dying to get because they're so anxious. So they want to know the experience. They are asking me as the mask goes on, what's going in? Can I hold my own mask? Can I push my own medication? I usually don't want patients to push their own medications, but boy, they will ask to no end until they're finally asleep. If they're having sedation, they're going to ask questions the whole time. Can I see my surgery? They literally want me to lower the drape, which I can't do because that would violate sterility in many cases, so that they can see the surgery. They ask me to set up mirrors in the operating room so they can look from the table back at the surgeon, back at their own body part. And they keep asking over and over again because a little bit of propofol will make that even more magnified. So that's openness. Now, the opposite end of that is the rigidity. Sometimes there are patients that are so rigid, they don't want anything that might put them out of their comfort zone or familiarity zone. And if you're thinking that patients that might be prone to depression might have that level of rigidity, or patients prone to anxiety may have more rigidity in that domain, you're correct. These are patients that might be prone to postoperative depression or kinesiophobia, which is a form of anxiety after surgery. So that's number 1, openness. Number 2 is conscientiousness. If we're going to go down the acronym OCEAN, that Lava mentioned. Hey, Michelle, good to see you on here, by the way. And by the way, Heidi's going to highlight the best questions out there, so I answer them as we're going along about these 5 traits. But conscientiousness was number 2. Thoughtfulness, impulse control, being goal-directed or organized are common traits that we see in the conscientious individual. Now, the opposite of this domain is going to be messy or disorganized. So midazolam death count is saying, if patients want me to film on their phone, would I be happy to do so? If the institution allows it, I am happy to do so. Those patients score high on openness. That was number 1. Good question. But number 2 is the conscientiousness. Are you messy, disorganized? How does that come up? How does your organization come up when you're under anesthesia? Well, you know you're not supposed to eat before surgery. many individuals, I can't say many, maybe 1 in 25, 1 in 30 will eat before surgery or before their minor procedures, forgetting. And it's like the opposite of patients that have a strict boom, 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 boom list of what they can and can't do before surgery. I'm not saying one is better or worse, and we need to recognize that under the stress of surgery, absolutely, you have situational variables that will confound our personality tendencies. But that being said, the stress of surgery, the vulnerability of surgery can make these certainly more amplified to reveal things about ourselves, and we'll talk about that at the end, because that's something that every patient can and should be mindful of for their long-term health. So the conscientious patient is one who's not likely to eat before surgery, not smoke a joint in the parking lot, because there are rules for not smoking, even if you're anxious before surgery. The conscientious patient's going to come in with that list of questions in the last minute before surgery, maybe not so much of curiosity of interest, I-type curiosity, which if you want to talk about, we certainly can. It's very important to understand in our basic, understand curiosity I-type and D-type. The conscientious patients might have more curiosity D-type, or what's called deprivational curiosity, need to know. As they're falling asleep, they're asking me, doctor, what can I eat before, or what can I eat after I wake up? Doctor, can I move my arm after I wake up? Doctor, when can I drive again? And this is like the last seconds before we're falling asleep, literally pushing propofol in the IV, but they have a checklist they need to go through. That's why it's deprivational curiosity, D-type. It's not bad, but it certainly has a telltale sign, especially in those vulnerable moments before falling asleep. The patients that are on the opposite end of this spectrum in this domain are the ones when I come visit them in PACU, when they're eating their crackers in their recovery unit, the post-anesthesia care, they had the crackers all over them and are kind of oblivious to having made a really big mess. Now, I feel bad for the nurses that need to literally pick up the crackers from these patients, but I'm not saying it's good or bad. Telltale signs once again. Versus the patient that's literally tucking the bed as they're walking away and to leave the PACU, the recovery area. That level of organization and detail is very amplified in these patients. Okay, number three is what straight talk, no messing is just talking about. So straight talk says, I get nervous beforehand, then I turn into the laughing type. So that's the extroversion versus the introversion domain. Extroverted individuals derive energy from social settings, being around others. They're the ones who walk into an operating room like this one, talking up a storm. They are literally joking with the staff as if they've known them all their life, as if they work in that operating room. And they're also prone to making jokes. And once you add the anesthesia into the picture, those jokes can become very inappropriate very fast. Maybe they didn't recognize that they had that filter going on, but I'm really happy they did have the filter before anesthesia, because those jokes would not fly outside of the operating room. That's why we say it's like Vegas rules in the operating room, because boy, the stuff that we hear in here is absolutely inappropriate, especially in individuals that are very strong in the extroverted scale. Now, I'm not saying it's bad, but you contrast that to the introverted one, who is someone who finds rechargingness by being alone in solitude. Here's a great question. What causes oxygen to drop a few hours after surgery? Does that have to do with the personality type? Not necessarily. The oxygen drop after is not related to personality traits so much, unless there's someone who's so concerned and fearful of the pain, kind of that rigid, which was number one, we said, right? Openness versus rigidity. I find that patients that are rigid, intolerant of ambiguity, are more likely to be asking for pain medications, and excess pain medications are likely to lead to hypoxemia or hypoxia hours after surgery. So there's patients that are so afraid of the pain, they might be accidentally overdoing the pain medications. Very good question. Number four is the A in the ocean mnemonic that Lava mentioned at the beginning, and that was agreeableness. The domain of agreeableness is someone who is kind, if you're strong in this, affectionate, compassionate, and empathetic. The opposite of agreeableness is being manipulative or competitive. Who are the ones that are on the other end of the spectrum in this domain before surgery? Who are the competitive ones? You tell me, and I'm going to give you a shout out because it is so stereotypical. When one of these individuals is about to go under anesthesia, it is not subtle at all. Who are the ones that are in the agreeable domain on the other end of the spectrum? They are the competitive type, maybe manipulative. Yeah, this comes up. You're greasing the wheels with propofol. How does it come up? I'm waiting to give that shout out. In the meantime, I do want to answer an important question that came up. Someone says men. G-Ball says the men are the one. No, it's not just the men. The ones that are competitive might be men. Maybe it's those college students who want to fight and see, doc, I'm going to fight this as long as I can. And they're tensing up all their muscles and they're so wound up as the propofol is going or as they're breathing the gas through the mask. And they end up making everyone's life a little bit harder because if they go to sleep with that level of, I'm going to fight this to the bitter end, they might wake up with more of that fight. And when you wake up fighting after surgery, it's not pleasant for anyone. Might be related to emergence delirium, kicking, screaming, maybe pulling out your IV. Fortunately, it's not very common at all because we do our very best to calm the competitive individuals so they don't wake up doing that. But it still happens sometimes. The manipulative patient. How does this come up under anesthesia? I don't want to say any patients are good or bad. I want to be very clear on that. But there are often patients that want to dictate care, which I always am supportive of to an extent, because patient advocacy is critical to you getting the best care you deserve. But sometimes a little bit of manipulation creeps in. And sometimes someone wants to get more of a certain medication for a particular reason and not tell me. If you can think of scenarios like that, they do exist, and they're probably more common than you might think. I'm not saying it's bad, but I want to make it very clear that when you're under the stress of surgery, you might be cold because these rooms are freezing. You might be naked because your gown is flapping your bottom open in the wind. You're hungry because you've been fasting. You're nervous because you're going to be cut open. A lot of factors are going on here that might make individuals a little bit less likely to be open and honest with me. And maybe they'll try to, for example, not tell me that they used a drug in the last 24 hours, or they did eat a sandwich as an early lunch before coming into surgery. All sorts of manipulate. Maybe they want a certain medication. So that's the opposite end of this domain of agreeableness. Now, who is very agreeable? This is important because there are some patients that literally the whole time, I'm not even making this up, are more concerned about the staff seemingly than their own well-being. They're asking the staff, are you okay? Are you hungry? Did you get enough to eat? Are you tired? Did you sleep enough? Are you comfortable? Is it too cold for you? You would think that this person was taking care of the whole OR staff. They ask me how I'm feeling, how I'm doing. And it's like, I appreciate the attention, but we're here for you, patient. You don't have to be concerned about our well-being. It's very kind. When they wake up from anesthesia, the first thing they wake up saying might be, thank you so much. I'm so grateful. Thank you for what you do. And I got to say, this is rare, but those individuals strike me as quite remarkable. And they tend to have very smooth recoveries in the absence of surgical complications that might otherwise turn them off course. Because they aren't focused inwardly, they're focused outwardly. They are looking at others empathetically, compassionately, and oftentimes it helps not distract from their own suffering, but helps place it in a perspective that might be absent in someone who is on the opposite end of that scale. Heidi is mentioning the private Zooms. I really appreciate that, Heidi. As you know, we do have private Zoom sessions that we try to have once a week or once every other week. The link is below in the description to sign up for our exclusive access group, where we can answer more of your questions on individual private levels that we can't get to in these large streams. But I do want to address what Ray Kirby said. Ray says, I have PTSD, depression. Before my cystoscopy, that's a surgery in your bladder, putting a camera through your urethra. If you're a boy or a girl, depends on how long that is. But watching you, I apologized and told her that I have that. She asked me my triggers. Wow. So you took your knowledge from what we've talked about in these videos, recognizing how PTSD and depression can absolutely rear their head in vulnerable situations like surgery. And looks like you were able to be more in control, recognize what you did, apologize. And I hope you recognize that the more control you have in stressful situations, the more confident you can be. And that is the antidote to anxiety and depression. Of course, there's many factors that go into this, but remember, confidence, control, and certainty. Confidence, control, and certainty. The 3 C's that I talk about are fundamental to our well-being. So Ray, I'm really happy to hear that. And I want to go to number 5 now, which is the one that everyone asks about, and that's neuroticism. What do individuals with high neuroticism do under anesthesia? What are neuroticism? So the opposite of neuroticism is someone who is resilient or stable, because when people are high in neuroticism, they are more likely to be emotionally unstable, unregulated, to not be able to be in control of the situation, kind of like what we were talking about earlier. Once again, not good or bad, but individuals that score higher on the neuroticism domain, on that scale, are ones that are more likely perhaps to wake up emotional, maybe more prone to the emergence delirium if they don't feel safe in the environment that they're having the surgery in. Once again, not judging, just sharing observations that individuals that have difficulty with that level of regulation, when you put them in stressful, high pressure scenarios like surgery where you have pain, unfamiliar people around you, once again, hungry, maybe naked, cold, this can absolutely result in individuals who are kicking, screaming, crying, emotional, even when they're not conscious of what they're doing. Perhaps because it's maybe ingrained in their subconscious, maybe from a history of past traumas. Everyone's narrative is a little bit different, and it does come into play under anesthesia. Now, these are all important because understanding where we lie on these 5 factors, like Teresa Lynn is saying, of one who fits in the 5th one may have a lot of medical trauma. You're absolutely right. If we are able to use what anesthesia provides us, which is a brief period away from the normal loops that we are always thinking in, it literally gives us an opportunity to step away from ourselves, giving us an opportunity to view ourselves differently, perhaps. Sounds a little bit challenging, but I've seen it happen time and time again in patients, whether they receive ketamine for their anesthesia or not. The eye is blind to itself. Any opportunity to look at ourselves from a different perspective can be very powerful for that reason. And that's why if we recognize what of these traits comes up, which of these traits, how far we are on the spectrum, whether it's openness versus rigidity or neuroticism versus resilience, when we have that insight and are able to recognize in ourselves where we are lying, where we land, offers a powerful opportunity for intervention that you may never have access to otherwise. There's one other altered state of consciousness that sometimes these come up in, and that's our dream state, which also can be incredibly healing. Cultures across the world have known this for years, but a lot of us don't get that opportunity to sleep in the presence of doctors and to have that experience be recounted to us in a way that might be healing. That can happen with anesthesia. It can happen with psychedelic experiences when done in medically appropriate ways. Heidi's asking about peer-reviewed studies. Peer-reviewed studies on these 5 factors are in existence. Certainly you can look them up. How they come up in the operating room has not been well studied because most people just look at anesthesia as a light switch that goes on and off, not giving any regard to how are these 5 traits coming into play when we're in these vulnerable moments. It's a really good question, and I really want us to ask deeper about what is being revealed about us in these situations so we can learn more about ourselves for long-term healing. What is the length? How does the length of surgery affect these things? The longer your surgery is, the more anesthesia you might get. The more anesthesia you get, the longer it takes to recover. The longer it takes to recover, the longer you're going to be in this twilight zone The longer we're in a twilight zone, the less inhibition we have. So a longer period of time that you're going to be kind of woozy. Now, depending on the type of surgery, you might still be coherent during the period of wooziness, or you might really just not be with it and not be saying very much. So your personality may or may not really be coming out depending on the length of surgery, but certainly before going into the operating room and maybe the day or two after, as our brain is recovering from the changes that happened during that interventional period, that controlled trauma that we call surgery, is a valuable window into our true selves. What are our coping mechanisms? Are they maladaptive or are they helpful? Why are they there? If we can understand why our coping mechanisms are what they are in these controlled yet stressful situations, it provides an avenue to heal them. Can you have more than one ocean trait under a single anesthetic? Absolutely you can, because all of us have openness, conscientiousness, extroversion, etc. It's a question of how far we are on the scale of each one. So all 5 of these certainly come into play. How much depends on you and where your personality lies. Lava Demon says, I hope there will be more focus on this topic within the medical community. It's quite important because if we understand our patients, heck, maybe we can deliver better care. And in this broken healthcare system, we really need better attention to individual patients and their needs. Do you agree with that? Let me know below. I would assume that you also appreciate just how important that human connection is. Otherwise, you could go to ChatGPT for your healthcare. Probably won't turn out as well. Let's answer a couple more questions on here. Miss Dilly says, are chronic pain patients and people on MMT more likely to wake up during surgery and in more post-op pain? Yes, patients who are taking medications for chronic pain, in particular opioids, are going to build up their tolerance. Now, we can overcome that by using a different class of opioid. There's about a 25% reduction in tolerance when you switch classes of opioids. But that being said, you need to tell your doctor what your baseline pain medication requirements are so that we don't underdose your pain medications during or after you wake up. Oh, by the way, if you could hit that like button and share what you've learned with others, I always really appreciate it. Helps me do this more often for you. And like I said earlier, the live access link below can help you sign up for our private Zoom streams so that I can answer your questions way more personalized to far fewer people. Much, much appreciated. Pseudoscientist says, I find this topic fascinating. Seems we're all wearing a mask. Yes, we are. And it's my patients specifically, when they come for ketamine, that they realize what that mask is. It's often shaped by fear, maybe by past histories of trauma, by all sorts of variables that we don't appreciate exist until we learn to take the mask off. Another question, do emergent surgeries have a higher rate of emergence delirium? It depends. It really depends. But you can imagine that the fear, uncertainties, and doubts before emergent surgery are probably going to be greater on average than for elective routine surgery. And that mindset coming in has, at least to a small extent, an impact on the delirium upon waking. Of course, there are other variables as well. No one ever dreams while under. Oh, never ever have dreams while under. Well, Lynn, many patients can have dreams. It depends on how deep the anesthesia is. Typically, when you're under general anesthesia, it's not REM sleep, so you're not truly dreaming, but you can certainly have experiences, depending on the depth of the anesthesia once again. Great questions. I wish I could answer them all. Janine, are you supposed to eat? Or doctor, am I supposed to eat a doctor? I don't know. Eat a doctor? No, don't eat a doctor. But before your colonoscopy, are you supposed to eat? No, you should not eat before colonoscopy. Always talk to your doctor. But I've never heard of anyone recommending to eat before colonoscopy. Eating after is much better. Is it normal to wake up from anesthesia and not be able to control your movements? Shaking back and forth? Yes, absolutely. I recommend you look up neurogenic tremors. We can talk about it on another live stream. But all mammals, upon emerging from anesthesia, appear to have a characteristic tremor of the proximal big muscle groups. So your quads, your pecs. And these movement tremors are very, very repeatable. No one knows why. I suspect there is a relation to the type of anesthetic used and perhaps that individual's past history of traumatic experiences that might be cathartically being revealed in that period of waking from anesthesia. But not much evidence to support that beyond my own anecdotes. I want to be very clear about that. I was in the ICU on propofol, says Sherry, for 19 days, and I had major hallucinations. So you absolutely can have visions, like I said, hallucinations, call them what you want. I just don't want to call them specifically dreams if we define dreams as being a result of REM sleep, because anesthesia or sedation are not the same as REM sleep. But you can certainly have experiences. Look no farther than ketamine and low-dose ketamine, which disrupts the default mode network in ways that we also see in some ways when we're asleep. So a lot of fascinating neuroscience that you guys are all getting at. I'm always freezing when I wake up from surgery. Yes, Barb, these rooms are cold. I also get cold sometimes. Sometimes I do squats to warm up in the operating room. Difference between emergence delirium from dreams versus REM dreams. Well, I don't know if anyone has actually put electrodes on individuals who are having emergence delirium because you probably can't report anything because there's so much muscle contraction, it would overwhelm the signal from the brain. But it is a brief period of time, the emergence delirium, versus REM dreaming, which can be for extended periods of time, or the effects of anesthesia. What a good question. Do religious beliefs have a direct effect on anesthesia? Not necessarily religious beliefs, but belief in our healing capacity and our confidence and certainty in ourselves and our doctors can have a profound impact on the anesthesia. Very good question. Is ketamine used in most general anesthesias? Usually not in the United States because we have so many other agents. It was more in the past. Very good question. IV ketamine is life-changing, says PMRACC. Yes, certainly I use it in my patients regularly, and it's very life-changing, absolutely. I hope you also had a healing experience. I'd love to hear about it if we could share someday. Does a robotic surgery require a specific type of anesthesia versus non-robotic? Not necessarily. Good question. What are sensors put on the head for surgery? The BIS sensor uses an algorithm to calculate how awake you are using information from those electrodes. However, it doesn't work for all anesthetic agents. It doesn't work for laughing gas, nor does it work if you're using ketamine, because they have totally different EEG signatures, meaning brainwave signatures. And we'll end with one last question. Would a drug addiction make you permanently affected differently to anesthesia? Very good question. Drug addictions can have profound effects under anesthesia, not only in changing the required doses, but also effects from the trauma that those addictions have. And it's not uncommon to have either emergence delirium, have worse postoperative pain, maybe the risk for depression or anxiety after, depending on what medications are used. For example, when I have patients who were previously addicted to opioids, I want to do everything I can to minimize the use of opioids because some of them can even tell if they've had opioids when they were under anesthesia. A patient once received a small amount of fentanyl during their surgery after having been sober for decades. They woke up and the first thing they said, looked the anesthesiologist in the eye. They said, "Did you give me fentanyl?" Blew my mind away that a patient, upon waking from anesthesia, had some sense that over an hour prior, when they were unconscious, had received an opioid. Can that trigger relapse? Theoretically can. That's why we absolutely need to listen to our patients, and their preferences matter, especially when they're trusting their consciousness and their mind and body to us. So you ended with a really good question. The bigger question that I have is whether we ever truly recover from addictions. While I don't have a direct answer, I can certainly say that anytime I've had a patient who was formerly an alcoholic, formerly an opioid addict, addicted to any other number of substances, even if they've been sober for decades, I find that they respond unusually to anesthesia. I'm not saying it is because I didn't run a study, I don't have a control group, but I will say that after years and years and years, I have found that particular patients appear to have long-lasting changes, not necessarily negative, but that the body keeps score. from any past traumas, whether drug-related or not, that do appear to impact how they respond to anesthesia. It's not meant to be scary. It's meant to recognize that our bodies are precious and keep score of everything that happens to them, whether we are conscious of them or whether we have suppressed it. And when the unconscious may become more available, maybe under anesthesia, certainly in certain psychedelic experiences, the score the body has kept can bubble up in very real ways that we detect on the life support monitors, like the one that you see behind me. Of course, we can ignore them and just move along with our day, business as usual, or we can pause to respect just how powerful our mind and body are and the connection between them, and how much power we have over our health, because it's probably more than you've ever been told. If you appreciate this, do please hit that like button and share what you've learned with others to empower your loved ones. If you ever need surgery, I'm wishing you the best. Till next time, peace.